Hi everybody and welcome to the IPDLN 2020. This is the abstract presentation session for communicable diseases. My name is Hannah Moore. I'm an infectious diseases epidemiologist at the Telethon Kids Institute here in Perth, Australia, and I'm going to be your session chair for this session. So in this session, we have 4 10-minute presentations, and then after the presentations, which will go one after each other, we'll then have 30 minutes of discussions and questions. So if you do have questions for the speakers throughout the presentations, please use the Q&A function to ask your questions, and you can enter your questions at any time during your presentation, and then we'll answer those at the end. So our first speaker is Professor Christen, who is from Australia, from the Australian National University. He is a professor at the Research School of Computer Science at ANU. He received his diploma in computer science engineering from ETH Zurich in 1995 and his PhD in computer science from the University of Basel in 1999. His research interests are in data mining and record linkage, with a focus on machine learning and privacy-preserving techniques for record linkage. He's published nearly 200 articles in these areas, including in 2012, the book Data Matching, published by Springer. And today he is going to talk to us about estimating maternal mortality rates during the 1918 flu pandemic using birth-to-death linkage. Thank you very much, Peter.
Thanks, Hannah. So let me just share my screen, and if somebody could confirm, can you see my screen?
Yes, we can.
And you can hear me as well. Excellent. Okay, thanks. Well, okay, so as Hannah said, so I'm actually a computer science expert. I'm not a health expert. So I'm not sure if you're going to be the right person to answer questions afterwards. But this is work done together with my colleagues in the United Kingdom. Actually, I'll go to our own cover slide here. Who work at University of Edinburgh and Cambridge, and it is part of the Digitalizing Scotland project, which I'm going to explain first. So we try to basically link historical data, and this is really a first case study of much bigger linkages which we're planning to do in the future. So Digitalizing Scotland is a project which is funded by the UK's Economic and Social Research Council, as well as National Records of Scotland. And the aim of the project is that we're trying to or we actually have by now transcribed all Scottish birth, death, marriage certificates from 1855 to 1973. So that's pretty much around 25 certificates. Once we have them, then I guess we want to link them together and basically we construct the whole population of Scotland from 1855 to 1973. And this will allow research access to individual level information that is completely unique worldwide and to tens of millions of people. So basically a large proportion of people who lived in Scotland during that time period. This will allow all kinds of investigations, including intergenerational social mobility, genetic patterns of diseases, changes in demography access, industrialization, immigration, emigration, and so on. So it's going to be a really exciting data set to work with. And what we've done so far is basically we have transcribed through some collaboration with Queen's University in Belfast and outsourced to India, basically the handwritten forms. And as my colleagues told me just recently, that the coding of occupation strings and causes of death has pretty much been completed now. So we're getting better with the data we have. What we haven't done so far is pretty much the linkage. So at the end of the day, at the end of this project, we want to pretty much reconstruct the whole population. So about 2 years ago, we started to think about what should the first kind of linkages be. So that was not 1918, that was 2018. COVID wasn't around, a flu pandemic was something hypothetical in the future. And so let's say we decided, well, let's start with a small case study by trying to link birth records to death records of women. And basically look at, can we calculate maternal mortality rates and compare the ones we get through linkage with the ones which have been studied by social and health researchers for quite a long period of time and see, do we get the same rates? And so we basically linked birth records from November 1916 to December 23 to death records of women aged 15 to 49. So candidates of women who gave birth, who died between January 1917 and December 1923. that cohort, or that number of records, is basically roughly 54,000 birth records or certificates, and about 800,000 death certificates. The definition of maternal mortality rate is a death of a woman in that age who has given birth up to 24 days before she died. And so we have basically a time period of a death only 42 days after a woman has given birth. So how did we do the linkage? We compared the parents' name on the birth certificate, so the mother and the father on the birth certificate of a baby, with the disease, so the woman who died after birth, and her spouse, as well as the addresses. And because these records are based on hand-transcribed, handwritten form, there's lots of data quality issues, and therefore we had to use approximate string matching. So it might be familiar with Jarrah Winkler. We use those on names and addresses. And so basically between each birth record and each death record, we calculated these similarities. Each of those similarities is between 0 and 1. 0 means two names are completely different. 1 means the names are exactly the same. We do this for names and addresses. That gives us a number between 1 and something like 6. And we scale it back into 0 and 1. Now, an important aspect, and again, this comes back to the idea of this initial case study, is to look at how do we actually evaluate linkage quality, because we don't have any ground truth data. So we actually don't know if the links which we have are correct or not. And this is going to be the challenge we have for the whole, any kind of linkages which we do with this Digitalizing Scotland data. So we conducted sensitivity analysis where we linked birth to death records with different similarity thresholds. So basically, again, we have a total normalized similarity between a birth and a death records between 0 and 1. 1 means they have the same names and the same address. 0 means they're completely different. And so we have these different thresholds. Every link which has a similarity above that threshold, we classified as a match. So we said this death corresponds to the woman who has given birth a few weeks before or a few days before. If the similarity value was below the threshold, then we said it was a non-match. It turned out that the whole approach is actually quite robust with regard to these results, and so the best results we got 0.8. I'll show a few example results on the next few slides. We then calculated the maternal mortality rate, MMR, on a monthly basis, and we did this for 3 different periods. We looked at the pre-flu period, which was January 1917 to July 1918, the flu period from October 1918 to March, that's the key where the 2 waves happened, and then the post-flu period, March 1919 onwards. We calculated the MMR for each month as the number of birth to death matches which we got for a certain similarity threshold, divided by the total number of births in that month. Okay, and so here are some of the results. So the first one is monthly mortality rate. So this is per 10,000 births. And as you can see clearly, the gray line shows that there was a huge peak in the number of women who died, right? So that's the maternal mortality rate. We also looked at the overall mortality rate of the population. As you can see, that's lower. And we also looked at, as a comparison, the female groups 15 to 49 who did not give birth in that period of time. And of course, they're more healthy, and therefore their mortality rate was much lower. So down here, you can see the impact of the Spanish flu, the two waves, and you can also see that the first wave had a massive impact on the mortality rate of women who gave birth in Scotland in the time period. Here we have a look at the different ratios we got for different similarities threshold I explained before. So down here are the different similarities threshold with different colors. And as you can see, and that's really important for our linkages, that the results are very robust, right? So it really means that if we have high similar matches between birth and death, then we get pretty consistent results, even though we change the similarity threshold quite a bit, right? And again, you can see the peak here of the 2 waves. And I have to say that 100 will basically be what one would expect the number of deaths to be in a month in Scotland. So again, that corresponds to the excess deaths which are now being recorded worldwide for COVID as a measure to see not just the reported death, the COVID reported deaths, but the actual extra deaths which are happening. Here for a numerical example, again for selected month, right? And just to show you that over here, we can see the mortality rate for the whole population, so which was nearly double during the Spanish flu, much, much higher, I guess, than it is at the moment, luckily. And for females, again, it was females who have given birth, it was even more higher than that, right? So it seems that in the first wave, especially at beginning the October 1918, a lot of women who were in their pregnancy, they were really suffering from the flu, and it seems that many of them died because in November, the ratio dropped quite a lot, which is quite interesting, right? Okay, so just to kind of close up, so this was really an initial case study to look at what kind of linkages can we do with the Digitalizing Scotland data set. We found that the risk of death for pregnant women was much higher than for the comparable female group and for the general population during the 1918 flu. And especially the highest risk was during the first wave, October 19. We'd like to do much more analysis. We want to look at what's the risk of babies born during the flu. Did they survive, or did more babies die very young? And again, this was, as I said, it was a really initial case study looking at what can be done with the Digitalizing Scotland project. And we were really exciting to kind of soon have, hopefully in the next few years, be able to really link that data together at the whole level of the whole population, so we can do exciting health studies and social science studies and demographic studies and so on. Okay, thanks for listening to my presentation.
Thanks very much for that, Peter. Oh, you got another slide? No, we're done. Thanks very much for that, Peter. It was yeah, fascinating to see data that's so old. So just a reminder to everyone to please post your Q&A into the live chat, and then we will get to those questions at the end. So thanks very much, Peter. Our second speaker today is Miss Mariette Smith. Mariette is a senior data scientist at the Provincial Health Data Centre of the Western Cape in South Africa. She has a background in clinical epidemiology, perinatal mortality, and injury mortality surveillance. And Mariette today is going to talk to us about consolidated person-level health data, improving tuberculosis surveillance and patient care. Thanks very much, Mariette. I'll hand it over to you now to share your screen.
Thank you. Just to confirm that you can see my screen and hear me.
Yes,
Hannah.
loud and clear.
Great. Thanks, Hannah, and thank you for the introduction. Hello, everybody, and thank you also to the organizers for the opportunity to present here today. Ooh. So when discussing tuberculosis in the Western Cape, let me just give you a quick overview of the public healthcare system in the province, which serves about 75% of the population, currently more than 5 million active patients. It is a high burden setting with HIV and TB leading, but chronic diseases and injuries are not far behind. Healthcare is provided on 3 levels, but patients are mostly seen at primary care and community clinics. Most of the visit information is captured in the hospital management system, and the 2 primary care information systems are run by the province and the city of Cape Town. They all share a unique health identifier, which is quite unique in our province and has been in use for more than 30 years. Then there are the multiple other routine information systems, all separate for laboratory tests, acute and chronic dispensing, and disease information systems for HIV and TB. Data are captured by clerks and are mostly reliant on a sufficient paper-based system. Just a bit more about the high TB burden in our province. Just in our province alone, there are on average 55,000 cases per year, which is more than Australia, Canada, the UK, and the US put together. And that relates to an incidence roughly 100-fold higher than most countries represented here. TB and HIV are still the highest ranked in terms of years of life lost, although intentional injuries in especially younger men, are rising. So it's then easy to understand the information challenges such disparate systems can lead to in providing TB care. More than half of our patients move around between facilities. Data is captured in different systems, and for example, information on comorbidities are not always readily available. Another problem is that even with unique identifiers, clerks may often duplicate folder numbers with different personal information, and it's then challenging to link that information together. There can be also insufficient data management expertise in healthcare workers and a reluctance to use new technologies. We have seen, especially over the COVID period, that people really love their spreadsheets, which are easy to email to other healthcare providers and can compromise sensitive patient information. And lastly, most hospitals are not TB reporting sites. So if a patient is not followed up at a clinic, the case may never make it into the TB information system. But we have been fortunate in the Western Cape to have a data center that daily integrates patient-level health data from all the systems I mentioned, centered around the unique health identifier or folder number. There are currently data from over 30 different sources for over 14 million patients. Data are added daily, cleaned, linked, deduplicated, mapped to concepts, and stored securely. The linked data can then be used to infer health conditions and care cascades, mapping an individual's path through the health system over time. Tuberculosis is just one such condition. So more information about the system is available in another talk. If you want to check it out, it's available on the system and it's by Professor Andrew Ball. So to infer a diagnosis of any condition, essentially backwards from electronic data, can be quite challenging because tests and treatments can span across different health conditions and source data can often be incorrect. But by triangulating many different sources and classifying data points accordingly, we have developed an algorithm that can reliably identify cases. Each case, though, has an assigned confidence level, which of course increase with more data points. So here's just an example of all the different data that we can patch together and create a case of TB. And after inferring a diagnosis, we can then generate a line list of all TB-related visit and treatment information for an individual for each time they are newly diagnosed with TB, which can be multiple times across their lives in our high-burden setting. The line lists are in continuous development with extensive consultation with clinicians and clinical managers in order to produce a set of information that will be useful and actionable where necessary. So developing these information-rich cascades can be very rewarding for us analysts. It needs to be presented back to healthcare workers in accessible formats. So the tools we have developed to this aim are currently available on two platforms: the Cascade Line List on a SQL Server reporting platform and a bespoke software called the Single Patient Viewer. The Single Patient Viewer presents linked information from all available sources for a particular individual, essentially a consolidated patient record with clinical details, counters, latest patient contact details for follow-up purposes. SPV also provides the ability to contact patients via SMS and phone calls and can also add follow-up notes for a patient. A relatively new development is the ability to make referrals to community health workers using an integrated mHealth tool called Catch and Match. So the same cascade line list that were previously presented on patient level can also be presented in an aggregate format for reporting purposes, and a vast number of indicators can be calculated to satisfy reporting needs as they arise. These can be generated on facility level or district or sub-district or province level as required. So in summary, because of the high burden setting, efforts are largely focused on catching missed opportunities for better patient management. Our consolidated data environment can and indeed has greatly improved on individual disease registers by deduplicating and linking patients across the platform, by identifying additional cases not previously reported in those systems using our disease algorithms, and by presenting data in actionable format to close treatment gaps for clinicians. Also by creating opportunities for tracing and referral via electronic platforms and linking to mHealth applications. But that said, the work is not done and there's always room for improvement. So we have learned a lot from rapid development of a number of tools during the coronavirus response in the province. The public-facing coronavirus dashboard has now made it possible to highlight other health conditions to the public. And as you can see here, TB identification and diagnosis has decreased quite a bit during this period, highlighting the need for TB screening and treatment. Also, another development that can borrow from the coronavirus response is our interactive case listing, which we can now repurpose for TB into a TB treatment action list to identify individuals who require active monitoring and follow-up. So thank you again for the opportunity to present our work, and I would like to acknowledge my colleagues at the data center and stakeholders who support specifically the TB work. And I've also added some additional resources for those who are interested. And thank you.
Thank you very much, Mariette. That's fantastic slides there and fantastic work that's been done there. And again, just a reminder for everyone, if you do have questions, I'm saving all my questions up and we'll ask them all at the end. So thank you very much for that, Mariette. Moving on to our third speaker now, moving from South Africa back to Australia. We have Dr. Jacqueline Stevens, who is an early career researcher and an epidemiologist who conducts research focused on improving access to healthcare services. Her research has used large cohorts and data linkage across infectious disease, chronic disease, and child health to identify health inequity, particular inequity impacting on Aboriginal and Torres Strait Islander peoples. And today, Jacqueline is going to be talking to us about hepatitis C in South Australia and in the Northern Territory, population-based data linkage study. So thank you very much, Jackie. You can now share your slides, please.
Okay, and just wanting to confirm that you can see that?
Yes, absolutely.
Okay, great. Thank you.
Thanks very much.
So thanks for having me present today. First of all, I would just like to start with our standard protocol in Aboriginal health, which is to acknowledge the Kaurna people as the traditional custodians of the Adelaide Plains, where I live and work. And I'd just like to recognise the Kaurna people's spiritual, physical and emotional connection with their land and pay my respects to their elders, both past, present and emerging, and to all generations of Kaurna people now and into the future. I'd also just like to extend my respect to any Indigenous peoples from around the globe who are joining us tonight on this conference. So first of all, I'd just like to give a little bit of a background about hepatitis C in South Australia. So in Australia, hepatitis C notification rates occur at 5 times the rate among Aboriginal and Torres Strait Islander peoples compared to non-Indigenous Australians. And a total of 10,000 hepatitis C notifications were reported in Australia in 2017 in SA. of which about 11% occurred among Aboriginal and Torres Strait Islander peoples. 39% occurred among non-Indigenous peoples, and the remainder were unknown Indigenous status. So for those people who are unaware, Aboriginal and Torres Strait Islander peoples in Australia account for actually 3% of our population. And so you can see with 11% that there is actually a much higher burden of disease among that particular population. And with chronic hepatitis C infection, you have potential complications such as severe fibrosis, cirrhosis, and hepatitis C related deaths, which have more than doubled in the last 10 years amongst people with chronic hepatitis C infections. So of people with notification of hepatitis C, you can see in the table at the bottom of this screen that Aboriginal and Torres Strait Islander people are actually having more notifications each year, while among non-Indigenous people it's remaining fairly static. So the aim of this project was to put together a data linkage in order to identify inequities in hepatitis C healthcare for Aboriginal and Torres Strait Islander peoples across South Australia and Northern Territory. And so with this, we want to assess the annual trends since the data started being collected, which was in 1995 and 1992, depending on which of the two jurisdictions you look at. So looking at hospitalisation and emergency department use, looking at long-term outcomes for those people as well in terms of cirrhosis and carcinoma incidents, and looking at other factors related to morbidity, mortality and excess mortality as compared to the general population. And we also wanted to evaluate the assessment, diagnosis and treatment uptakes and outcomes for these people based on geographic location to identify where gaps in service delivery may be occurring across the two states. So the cohort is hepatitis C notifications, and across the two jurisdictions we anticipate there being about 25,000 cases. For those of you who are unaware, South Australia is in the green, Northern Territory in the orange, so really the middle corridor of Australia. And we're linking 16 data sets using probabilistic linkage with the help of the SANT Data Link team, who are situated across the two capital cities in those two jurisdictions, and the Australian Institute of Health and Welfare Data Linkage Unit, which is based in Canberra. So the governance for this, because it involves the investigation of issues relating to Aboriginal and Torres Strait Islander people, needed to be particularly concerned with privacy and making sure that the research is being done respectfully and also with reciprocity. So we have on our team a range of different people, including our principal investigator, who is Aboriginal and Torres Strait Islander person, also governance from a variety of ethics committees, which includes Aboriginal and Torres Strait Islander ethics committees in both states, and a project steering committee, which includes a range of health workers and clinicians based in the Aboriginal health workforce. So our data sets include the core data set, which is a hepatitis C data set, linking with data from cancer registries, pharmaceutical registries, justice, hospitalisations, and our national Medicare and deaths data. Our data linkage in South Australia and Northern Territory follows this framework where we have the SANT data linkage coordinating the interactions with the custodians for us, and the data gets uploaded into a Sure workspace, which is a secure online platform, de-identified, and that's where we do the work within that particular platform without removing the data. And so we have a range, this is quite a busy slide, I do apologise, but we have a range of data sets linking in together. We've got the ones in blue coming from the national data sets and the ones in green coming from the jurisdictional data sets. And because the Northern Territory has a different set of legal requirements, there's a slight complication in that there's a two-step process with the data being linked from the data linkage unit through to the national data, which does mean that there was extra governance required around that process. And then eventually, once that's all linked together, we will be able to access it. And so the original plan was to be able to provide you with some results of this linkage, but of course there have been challenges with this process. We actually started this process in 2017 and it is ongoing due to the complexity of the governance across the different jurisdictions and working in with their national data sets as well. We have also been hampered by the Covid-19 pandemic, which meant that the core data set of hepatitis C wasn't able to be extracted because those staff were all busy doing Covid-19 contact tracing. We've had issues around confidentiality of the hepatitis C patients, and so there has been a lot of discussion around how to do that linkage safely. And as I mentioned, different jurisdictional legislation requirements. Just like to acknowledge my team, which includes our next speaker, and thank everyone for your time today. Thank you.
Thanks very much, Jackie. It was a fantastic presentation. I'm sorry you're still waiting for your data. We can maybe talk about that in the question time. You have reminded me it was completely remiss of me to not do an acknowledgement of country. I'm also in Australia, so I do apologise for not doing this earlier, but I would like to acknowledge that I'm standing on Noongar Whadjuk Whadjuk here in Australia, in Perth, and I'd like to very respectfully pass my acknowledgements to traditional custodians of the land and my respect for elders past, present and emerging. It's especially important at the moment because it's NAIDOC week here in where we are. So NAIDOC week celebrates the history, culture and achievements of Aboriginal and Torres Strait Islander people across Australia. So I apologise for not doing that at the beginning. Thank you very much for having your acknowledgement to country there, Jackie. Okay, moving on to our final speaker in this session, and please do remember to put in your questions in the live Q&A chat. There's a couple that are coming in, so please do remember to put those in. Okay, our final speaker today is Dr. Clare Bradley. She's also from South Australia, from the Health and Medical Research Institute in Adelaide. She is the study coordinator for the Centre for Research Excellence in Aboriginal Sexual Health and Bloodborne Viruses, and is based at the South Australian Health and Medical Research Institute. Clare also holds academic status with the College of Medicine and Public Health at Flinders University. She has extensive experience in the fields of health surveillance, health services research and data linkage involving primary healthcare records and government administrative data sets. And today she is going to be talking to us about a new national health service surveillance system in Aboriginal primary care called the Atlas Project. So thank you very much, Clare. And if you'd like to now share your slides, please.
Excellent. I hope that's working. Thanks, Hannah. Thanks for that introduction. Please sing out if this isn't coming through. Good evening, everybody. As Hannah said, I'm going to be talking about a new national health surveillance system for Aboriginal primary care services, what we call the Atlas Project. I'm presenting tonight on behalf of our Chief Investigator, James Ward, and the rest of the Centre for Research Excellence in Aboriginal Sexual Health Investigator Group. My acknowledgement of country is that I acknowledge and respect the traditional custodians of the land on which I live and I work, the Piramak and Kaurna people of the Adelaide region. And I pay respects to the custodians of all of the nations that are represented in the audience today. Sovereignty has never been ceded, and it always was and always will be Aboriginal land here in Australia. So the rationale for this work was that there's a much higher burden of sexually transmitted infections in Aboriginal and Torres Strait Islander people, about 3 to 7 times higher in Aboriginal people and Torres Strait Islander people than non-Indigenous Australian populations. And these are quite easily treatable bacterial infections that shouldn't have that disparity in burden. of disease. We're also noticing divergent trends for HIV, and as Jackie explained in her previous presentation, and hepatitis C rates. We have a national notifiable diseases network, but this data only reports positivity without a contextual testing data that lets us know what it might be causing any changes observed in the notification system. This data system also is, of course, limited to those diseases that have been declared notifiable, and it still has problems with completeness of our Aboriginal and Torres Strait Islander identity. And in some states that's worse than the others, but overall it's still not a good scene. With over 140 member services, Aboriginal community-controlled health services are the single most significant point of entry to the health system for our Indigenous peoples. These services routinely collect STI and BBV clinical data as electronic medical records. And whilst these are used within the system, within the health services themselves to inform their clinical care assessments, at a population level, these data are an underutilised resource and can be used to help drive clinical and public health interventions. The objectives of the Wada Centre for Research Excellence in Aboriginal Sexual Health was firstly to establish a national sentinel surveillance network of Aboriginal health services to contribute to our knowledge of STI and BBV prevalence and management in Aboriginal populations. So this is this Atlas network that I'm discussing today. We wanted to do this to be able to identify strengths and gaps in clinical care for STI and BBV in this setting, and to be able to support continuous quality improvement processes in the health services in the network. We also wanted to be able to strengthen research capacity with our participating organisations, collaborators and our investigator networks, and we wanted to be able to meaningfully contribute to policy and program spaces. For the Atlas network, our approach was that we primarily wanted to to collect our data through extractions and de-identifications process using the University of Melbourne's Granite software. This software sits with a standard installation of this software sits within a health services patient management system and can automatically extract and de-identify data and send it through to the research team. In other situations, we can use a standalone Granite hasher for electronic medical record systems or organisations that don't permit the standard installation of Granite in their systems to be able to de-identify and attach a hashed linkage key to records that are produced by the service themselves. In some cases, we've had to use direct extraction of data and direct data delivery separate to any Granite processing. This is workable but hasn't been ideal because it doesn't facilitate linkage amongst the network. From whatever source we get the data from, it comes to the research team currently at the South Australian Health and Medical Research Institute and is stored in SQL databases and analysed and visualised using R. Our outputs include a static surveillance report which addresses 12 clinical indicators that are considered best practice to STI and BBV control and management and generally align with clinical guidelines in most jurisdictions. We're also developing an interactive dashboard which not only gives a more flexible access to the data, but also goes some way to keep Aboriginal data in Aboriginal hands by having the control of that and of both the data and the analysis and the outputs in the hands of the services themselves. We're also able to produce data sets for approved researchers, whether or not they're part of our research team or networks where people can apply and have the de-identified data provided to them, given HREC approval and other approvals. And the high degree of standardisation and automation of our approach means that we'll be able to contribute, will contribute to sustainability of the network over time. Substantial amounts of the last 4 years has been in infrastructure development, and we've developed project-specific Granite interfaces for the most common management systems that we'd encounter in the sector. And we've also put additional work into trying to get Granite to interface with the MEX patient management system. Initially, we've been deriving data from MEX just directly by developing some reports that extract line-listed data from using the ISA Insights data visualization proprietary software that is associated with MEX, but also now a Granite interface for MEX which utilises the de-identification processes that Granite is so useful for. We've put substantial development into our coding scripts to receive and verify and clean this highly diverse incoming data that is, yes, pretty much every service stores and codes and stores their data differently. And we've used a lot of natural language processing to translate many of these free text data fields into a largely numeric system so that analysis is facilitated. We've also put some work into further developing the Granite hash linkage keys to create a custom ID generation protocol, which improves linkage both within health services data and also between health services in the network. Oops, sorry. So when data comes into the system via the Granite tool, it's fully encrypted like this. We are able to de-encrypt that, but it's still largely, it's understandable when you're just reading it, but it's not easily analysable at this level. So a lot of our coding and scripting goes to producing a quite standard and coded data set, clean data set for both ourselves and our automated reporting scripts to read, but also for sharing with other approved researchers. And we'll keep this with this Granite hash here, which contains no element of personal data, that so is completely unreversible. So then we've developed this dashboard. We haven't implemented it yet, but we're about to in the next month or two. And the driving kind of purpose for that is to be able to create customizable visualizations for the health services contributing their data, where they can either focus on particular aspects of the data that's of local interest, maybe particular age groups or particular infection types. We're building in a benchmarking comparison capability in this so that they can look at either services of a similar size or in a similar geographic region. But also they're able to do some customizing of the downloads available from the dashboard, either creating surveillance reports for a different time frame than our regular reports that are generally on a 6-monthly basis, or adding or subtracting different elements for those reports, as well as being able to download kind of knowledge translation products like PowerPoints or infographics that can be used within the service to share the results. The current status of the Atlas network is that it includes 32 different health services and communities arranged around 5 clinical hubs in Australia. Most of these are in very remote or remote regional areas. To date, we've got 61,000 individuals aged 15 years and older as part of the data set. And most of our clinical hubs are now using Granite for data extraction, which is facilitating linkage throughout these hubs. I don't think I said before, but if the same personal information goes into the system, Granite produces the same hash, identification linkage key, whether or not that record has been generated in a particular service or a particular jurisdiction. It's the same all the way throughout the network, facilitating linkage in a highly mobile population. So in sum, we've been able to establish this integrated network of sexual health primary care data, and we're using a highly robust and sustainable processing approach. Our network can be readily expanded because we've been able to develop these interfaces for all of the patient management systems in the sector. We are able to easily add new sites to the network as long as we have HREC approval and all of the documentation and paperwork sorted out. But we can also link our data to other data sets or surveillance systems using Granite as the extraction tool as well, because of this sustainability or the consistency of the de-identified linkage key across these systems. So Atlas has also established a very unique data infrastructure in Australia with capacity to support novel research programs as well as underpin CQI in participating sites. Our future is looking good. While the CRE's funding period ends at the end of this year, we've managed to secure some funding to support Atlas continuing through to 2023, although we're currently moving this to the University of Queensland, where our Chief Investigator, James Ward, is now based. And we're looking to not only continue but expand the network, both adding extra sites, maybe clinical hubs, but also looking to capacity to make it wider than a sexual health network, to look at other infections or similar types of pathology data that comes into the primary care system on a regular basis. And if anyone would like to follow up, we've got a paper on establishing the Atlas Network, just in a recent copy of BMC Health Services research. Thank you.
Thank you very much, Claire, for that lovely presentation. And I'd just like to thank all of the speakers that we've had in our session. So we are now open up to the Q&A. So for those of you that have questions for our speakers, please do use the live Q&A session, and then I will do my best to moderate those. So perhaps just as a quick refresher, we first had Peter Christen talking about digitising Scottish data from the 1918 flu pandemic and looking at maternal mortality rates. We had Mariette Smith from South Africa talking about some data systems looking for tuberculosis and clipping together all of these public service data that you have in South Africa and how that can be used for potentially some other questions outside of TB, perhaps. Then we also moved back to Australia, where we had Jackie Stevens talking about a fantastic data linkage project where we're still waiting for some data for, but putting together some Commonwealth data and some Northern Territory and South Australian data to look at hepatitis C. And then finally, we just had Clare Bradley there talking about the infrastructure and setting up an integrated system for sexual primary healthcare across Aboriginal community controlled organisations. So some fantastic presentations there and very diverse. So let's go to the questions. Okay, I'm going to start with this question from David Preen. It's a question for Peter. How long did it take and what were the costs to digitise the extensive historical mortality data from paper records for the entire Scottish population? Peter, over to you.
Yeah, thanks, David. Interesting question, and I don't have the full answers to this. So the Digitalizing Scotland project, I believe, started in 2012. Christen, who most probably you know, David, is the project leader. He's the person to talk to about exact costs and things like this. So from my understanding, it's pretty much the first digitization of the whole thing was planned to happen in around 16 or 17. A company was engaged and the contract was signed, and they came back very quickly that they couldn't do the transcription for the estimated cost at the agreed quality. As you can imagine, these are the handwritten birthdays and marriage. It's not just mortality data, it's birthdays and marriages. And so then Chris had to renegotiate, and they came up with a system where Queen's University in Belfast, they have a digital support unit, and they developed a system which was accessing the images in national records of Scotland on a secure server in Edinburgh. And the web-based system was then basically used by a company in India, while all the data was still in, as I understand, in Belfast as well as in Edinburgh. It cost several £million. Again, Chris would know the details. It took 2 or 3 years, the whole thing. If I remember correctly, we visited Belfast in 2018, actually at the previous IPDLN, was it? No, it was a Administrative Data Research Conference in the UK. And they only just recently finished, I think early this year, with a transcription, basically typing everything into a very clever system how to develop this. The coding of the occupations and death descriptions, so they're basically long textual strings. They're not our usual kind of short descriptions of an occupation or of a death. There's some really heartbreaking, very long descriptions of people in Scotland getting drunk in the pub and rowing across from one island to the other and drowning and getting hit by a horse and all these kind of things. So that coding was pretty much done by University of Edinburgh. They have a natural language processing group in the computer science area, and they've done that. And the linkage is still the stuff which we have to do, right? So that's the long answer. The short answer is ask Christen for the details of money and exact time and all that kind of stuff. It's been a huge undertaking, but I think it's going to be a fantastic data set, which is going to be worldwide unique if we manage to link these 120, 30 years together into one virtual population.
Fantastic, thank you for that. Peter, while we're on this topic, let's stick with another question for you before we move to the others. So this question here is posted from an anonymous viewer. Thanks, Peter, very exciting research. I was wondering whether you could identify any interesting findings from Spanish flu in 1918 that might be useful when facing the COVID-19 pandemic.
Yeah, so that question. And as I mentioned at the beginning, I don't think I can really mention much about this. I'm a computer science developer of linkage algorithms. I don't know much about the actual medical or historical outcomes and how they're comparable, right? I mean, so this was really a first initial case study where we were more interested to show, can we do linkage of such a historical data set where we have no way to know, to validate the ground truth. There's nothing else we can use. All these people are dead. Well, most of them, I guess, there might be some very old people left. And so we're really interested in the methodology and how can we link in a robust way and basically come back with results which are comparable to what historians and health researchers have done using other methodologies. And that's what we showed, right? I don't know what the comparisons will be with COVID. I mean, we saw the 5-time increase of mortality rate for women who gave birth. I hope it's not as bad for COVID, but again, I don't know the medical details. Maybe somebody else in the audience or that of the panel knows much more about that than I do. So apologies about this. Again, hopefully in the future we're going to have many more papers coming out of this project.
So I just carrying on from that issue, Peter. I mean, what lessons can be learnt from going back and doing this project? If taking this forward, not so much maybe understanding epidemiology of infectious diseases, but perhaps what are the lessons that we can learn from this in terms of doing linked data for the future?
Good question. Well, I guess the methodology that we try to come up with robust techniques which don't require ground truth data is a really big one. So I've been working in this area for the last 20 years or so, and often we assume we have some form of ground truth data, which kind of some external data where we know these two records must be the same person, right? Even in practice with modern data, this is very difficult to get, especially as we start to link data across organizations, and we've seen that can take years, and often it's not even successful because of privacy and confidentiality concerns. So in a way, we're in a similar situation now that we don't have ground truth data not because the people are dead, but because of privacy and confidentiality, we cannot look at the actual data, right? And so if we're able to develop robust algorithms, which we can then validate through other, again, in the example of the maternal mortality rate, where we look at what has been done in the health domain for the same situation in using other methodology, then I guess we can use the links we are getting, compare them with what is being obtained with other methodologies, and that will be again useful for what is happening today, right? And then of course the whole big picture is that we can for the first time look at several generations of people and look at I mean there's initial talks with NHS genomics. The NHS in Scotland has a genetics not sure what the name of the group is, a genetics group which basically helps people with rare cancers to find their ancestors and then look at are there any patterns in the way their grandparents and great-grandparents died. And at the moment they're doing this manually, so that it sometimes takes them weeks to find the paper records of somebody with a rare cancer and then look at what happened with their ancestors. And if you can basically do this again on a population scale and go back 150, 60 years, I'm sure we can identify lots of highly interesting, completely novel patterns of diseases, as well as things as migration and the whole social mobility aspect, which is completely out of the health domain. So I think it's fascinating, and I look forward to continue working with them.
Oh, that sounds great. Thank you very much, Peter. Okay, I've got a couple of questions here for Jackie, if you'd like to unmute yourself, Jackie. First of all, a question from William Ball. I think it's William Ball, not William Bell. I'm sorry, William, my eyes are going a bit funny at the moment. He says, thank you for your presentation, Dr. Stevens. I just wanted to ask how much input you might have had from Aboriginal and Torres Strait Islander people in the design of your study.
Yeah, so the original data linkage project is modelled on similar work by our colleagues in the Kirby Institute in New South Wales. And so we were looking at their data linkage and using that to inform how we did ours, hence they're collaborators on our project. Our work is a whole of population data linkage, but it is driven by the fact that there are Aboriginal and Torres Strait Islander peoples experiencing hepatitis C at a higher incidence than the non-Indigenous population. As you would have heard already from both myself and Claire, our principal investigator for both projects is Professor James Ward. For those who don't know him, he's a very prominent Aboriginal and Torres Strait Islander person in Australia, working within the STI and BBB space. And we also have the project steering committee, which is in development but is currently being reconfigured due to some personnel changes. But essentially that is made up of not only the investigator team, but also Aboriginal and Torres Strait Islander health workers working in the space and other prominent Aboriginal and Torres Strait Islander people within hepatitis across the two jurisdictions. And so once the data linkage is established, while we have those sort of overarching aims of what we want to look at, the actual data analysis will be driven by conversations with the project steering committee, who actually have oversight over the exact analysis that's done, and also have oversight of the interpretation of the results and how those results get published and framed, and the dialogue that surrounds those results. So there is a lot of input that has already occurred from Aboriginal and Torres Strait Islander people onto the project, but there is also that governance structure that sits around what will actually happen with the data linkage once it's established, and what questions we will interrogate of the data and how that will be framed. So that's a good question though, thank you.
Fantastic, thanks for that, Jackie. Jackie, there's another question to sort of follow on from that. So from your presentation, when you eventually get the linked data, you'll have a very rich data set that involves 16 data collections. And are you also planning to use these to investigate any other infectious diseases other than hepatitis C?
Yeah, so the data linkage actually does also involve hepatitis B, which is also another form of hepatitis that occurs at a greater rate among Aboriginal and Torres Strait Islander peoples that compared to the general population of Australia. So the data set will be hepatitis B and C, but I did just focus today on hepatitis C for simplicity. And we are also looking at co-infection of HIV amongst that cohort to look at whether or not there is, because there is some evidence to suggest that they do occur, often together as a co-infection. So there is also part of the linkage looking at the HIV National Registry, which sits at the Kirby Institute here in Australia, and they are tasked with doing a national registry for the whole of Australia, and they're tasked by the government to do that and feed into the national reporting. So again, another reason why we're working closely with the Kirby Institute. And so they're the two So hepatitis B and C and HIV co-infections amongst that cohort is the focus of that project, but we don't have any plans at this stage to expand it to include any other infectious diseases, but we are hoping that once it's established that we will be able to do some further linkages along the timeline so that we can sort of make it a prospective data linkage. So the initial setup will be the retrospective data, and then we'll be able to sort of continually do it every 2 years to continue to monitor. And that's really important at the moment because the introduction of new hepatitis vaccines, but also medications, which now means that hepatitis is no longer a lifelong illness, is something that we want to be able to monitor, and how that impacts on the incidence amongst the population. And also there is some evidence to suggest that Aboriginal and Torres Strait Islander people aren't aware that those medications are available to them, and so there may be opportunities to provide that information or services to particular areas or populations across the 2 jurisdictions.
Great, thank you for that. We've just got a question for Clare now. Clare, is the custom ID based on Granite allow for variation in the input information, or only able to be deterministically linked to new input data? If you could come online.
Good question. So each Granite data extraction consists of several different tables, and in each of those tables are a handful, I think it's between 1 and 4 different hashed IDs, depending on different combinations of the personal input information in there. It could be name, age, date of birth, if that's present or absent, Medicare number, that kind of thing. And the hashed ID can be different in each of these tables for the same patient service event. So what our custom ID does is it looks across all of these different tables and comes up with a kind of probabilistic matching of the hash IDs, and comes up with a more educated guess, I think it would be. I'm sorry, you're getting the non-data scientist answer, whereas if we have my data team here, they'd be able to explain to you much greater detail. But the idea that Peter suggested, that it's very difficult working with this linked data and being able to assess your processes without a ground truth. We have that same approach here. What we are finding though is that the custom ID generation process is getting us demographic data, like patient numbers, that are much more in line with what the services themselves feel comfortable with, whereas before we were getting too many patients because we're getting different IDs for the same person. And and we were also finding more incomplete kind of episodes of care. So someone might be getting a pathology test ordered, but no result came into the system as far as we were able to see. Now that we've got the custom ID, we've got better patient numbers according to the services that we're reporting to, and we're having more complete patient care within those records.
Hi Claire, it's Brooke here. I'm just going to send you a question in the chat because we've just had Hannah drop off this call.
Oh.
It's a question for you. If
Okay.
you'd just like to have a look at it there, and everyone else, if you can keep an eye on the chat, I'll pop in the questions for you.
Okay, so the question is that, another one from Paula, thanks Paula. What additional fields were used to create the custom ID, and how has it improved the linkage results? It has, I don't think it did bring in any more fields other than really looking at the hashes across the service event in the different tables. And how has it improved the linkage results? We're getting better numbers according to the services that we're doing. Sorry, it's a very difficult, because none of our data systems are, none of our data goes back to the you know, the personal information, that's all completely behind a firewall in the services. We never get anything like it. It is difficult to assess that. And also because of the consistency of the linkage key across time and space, it would be a privacy breach to work with a particular service to audit their records, because if John Smith in one service was given a particular granite ID, that would be the same across the other every other network health service if they ever attended there. So we can't really do the kind of auditing that would be gold standard. But as I say, we are getting numbers that we would believe better approximate the patient numbers that the services themselves are reporting, and the kind of anecdotal comparison with what they believe their testing and management rates are. Okay, it looks like I'm still in the hot seat because Hannah's not on the call anymore. So, Mariette, I think there's a question for you. Can you please talk about how clinical and research needs converge in CT?
Hi, yes, thank you for the question. That talk I mentioned by Prof. Andrew Bull actually focuses on that. So if you want to check that out. But I can say that initially the data center was established for patient care primarily, and research is sort of last in the queue because yeah, it's not primarily data that should just be used for research. But we do have a system where we release data sets according to protocols, and when all the necessary ethics clearances and everything is sorted. So yeah, we do definitely release data sets for research. We also release data sets for operational research. So people who work in the services that need numbers of certain conditions, we can do that. Does that answer the question? I hope.
Oh, Hannah's back.
Hello, I am so sorry about that, everybody. Oh my gosh, I'm so sorry. I had a complete technical malfunction there. I do sincerely apologize for those speakers, and I hope I haven't. Oh gosh, I'm so sorry. Okay.
So in your absence, Claire answered another question, and Mariette just answered a question as well.
Fantastic. Okay, so let's see. We have actually, I wanted to ask Mariette a question as well, so I might take that prerogative now if that's okay. Mariette, I was wondering to know. I think it's fantastic that you've managed to pull all these data systems together, and I can really see its usefulness and understanding and helping with patient management and clinical management, patient care. Is there the ability to use this resource as a research resource as well? And will the data be available for any researchers to be able to look at the data to understand some patterns and trends and other epidemiological research questions?
I've just answered that question,
Oh!
more or less. Sorry.
I'm so sorry.
Your question is a little different. Thank you. So we have definitely data requests that we release when all the paperwork is in order and ethics clearances and whatever. And we try and do that on an anonymous basis, so de-identified data sets for a specific study. So we've put down quite good guidelines to make sure that patient privacy is protected. But definitely, yes, we do release data sets for researchers when, yeah, they have to apply, and then it goes through a process.
Fantastic.
Yes,
Okay.
thank you.
Thank you for that. And I do apologise again for making you say that again. Okay, so there's just another comment here from an anonymous person saying real-time data in a middle-income country, I think is fantastic. So that's great. I think, Peter, there was another question here from you. You may have covered it, but perhaps since we have about 8 minutes left. It's another question from you. So going back to when you digitised all of that data from the Scottish data set, what particular software was used to digitize it?
Yeah, again, unfortunately, that's something I can't really answer in much detail. My understanding is that the digitization for microfilm and from the actual paper-based forms to microfilm was done by National Records of Scotland a long time ago. And then again, they took care of the digitization into images. And then, as I mentioned, a company in India was basically engaged to do the actual transcription. But again, I don't know the details of that part of the project. Again, Christen of the University of Edinburgh is the person to talk to if you're interested in the details of how this was really done. That's all I can say, really.
Fantastic, thank you. And Peter, while you're there, another question that I had, you said at the end there that you were then going to look at the some of the risks for infants using the data. Can you just explain a little bit more on what you would be doing there?
Right. Again, one of the questions which I'm not an expert about, right?
I know, I'm sorry.
It's kind of, again, it's kind of expanding the linkage to kind of see we have the birth record, right? And then we're looking at again, Alice Reid and Ely Gareth from Cambridge, Edinburgh are the experts. They have been working a lot on maternal death and mortality rates in the United Kingdom. So the idea would basically be to link birth records. Now we're not looking at the mother, we're looking at the baby, to a death record in a short period later on, right? So kind of see how many babies survived and how many babies died. And so again, here we will basically look at, again, the birth parents would be the parents of the deceased person. And so the idea would be, again, we're looking at what's the difference of the survival of babies who are born during not the COVID flu, and so the Spanish flu, the 1918 flu, before and afterwards. And I guess most probably afterwards is going to be more interesting because many mothers will have caught the flu, even if they weren't pregnant or they were early in the pregnancy. And so the question is, what about the survival rate of the children, right? And again, the things we can actually look at, not just the short-term survival rate. Once we have linked the whole population, we can really go through and try to link every death to a birth from the flu period, right? And so we can basically look at did the children who were born during the flu period or shortly after, what were the effects of the flu on their life? Did they have development issues, intelligence issues? I don't know, right? This isn't something which the health researchers and the historians would be highly interested in, right? But again, it's one of these many, many different possibilities of what we can actually link once we have the whole population and really look at temporal aspects and these events, which I believe nobody's done so far at that scale and for a whole country pretty much.
Oh, sounds fascinating. Okay, well, we're almost at the end there, so I'm going to give people another last minute to put any questions in the real time in the Q&A there. While anyone's thinking of some last burning questions, I am just here to also inform you that the recording of this session will be available on the conference platform in about 48 hours time. And if you enjoyed this session, you might also be interested in today's featured on-demand videos and posters, and you can find them in the on-demand gallery. And I think that, I'd like to thank the conference organisers. I think this virtual networking platform is going fantastically well. It's just unfortunately my technical inabilities let us down a little bit this afternoon. Okay, look, it looks like there's no more questions coming through. So I would like to sincerely thank our 4 speakers in this session. And I would encourage you all to go to the Network Hub and really try to meet up and connect with some like-minded people from all over the world. I'd like to wish you all well for the rest of the conference, and a very good evening or good day wherever you are in the world. So thank you very much.
Thanks, Hannah. Thanks, everybody.